Covering today's webinar will be myself, Amanda Gartner, Corridor's Clinical Analytics Manager, along with Mary Deagle, the Senior Manager of Compliance and Education. We are certainly excited to have the opportunity to talk with all of you as we prepare and transition to this new payment model. As you know, the diagnosis coding will impact 2 of the 4 payment categories, thus getting the right patient information from intake will certainly be really important in our partnership and in our success. But it's really not only intake's responsibility. Obviously, it'll be corridors, the coders, the clinicians, anybody who's a part of that admission team. We all need to make sure we have a good understanding of PDGM. So for the next 60 minutes, Mary and I will cover some PDGM highlights and best practices and leave some time at the end to answer your questions. Throughout the presentation, if you want to type your question into the chat box, you can certainly do that. And Mary and I will take some of those at the end if time allows. Any questions that we don't get to can be sent to the education station at corridorgroup.com. And this information is shared with you at the end of the slide deck. We will start today's conversation by first covering the 4 main elements of the PDGM payment model. I will also quickly highlight the differences between today's PPS model and the PDGM version. And then Mary will take us into the coding aspect of the model, talking about how the primary diagnosis falls into the various clinical groupings, followed by the none, low, and high comorbidity adjustment that we'll now get, and the need to have the specific patient information to avoid those non-acceptable codes. Mary is also going to cover for us the controversial differences between coding guidance and the COPs. And then we will also cover one of our favorite topics, the face-to-face, and how this document or requirement fits into PDGM and the focus of care or clinical grouping. And then finally, I will wrap us up on how the OASIS plays a role in the functional level of the payment model and what Corridor uses to make changes to your guys' OASIS. So let's get started. Some of you may see this graph in your sleep and have it memorized, which hopefully many of you do. And as we were saying earlier, there will be 2 components of the payment model that is driven by the diagnosis coding, with one of those being obviously the primary diagnosis or focus of care will be grouped into one of the 6 main clinical groupings. And MMTA does have some smaller categories, which brings it up to 12 groupings, and I'll talk about that in a minute. But the second component that's attached to diagnosis coding is the comorbidities, or the secondary codes, giving us more of an opportunity for additional resources if there are certain combination codes for the high comorbidities and some other certain codes for the low. Doesn't have to be a combination, but it's certain codes to give you the low comorbidity. And again, we'll touch base on this component in a minute. Then we also have the functional component where the ADL scores in the OASIS along with M1033, risk for hospitalization, play a role in providing additional resources that will be allotted to you to provide care to your patients. So really there are 3 out of the 4 elements to the new payment model that we have some sort of control over. The admission source and timing, it is what it is, and it will be claims-based and not based on the OASIS. And so for the purposes of this call and our partnership together, we're going to focus on those other 3 areas. Here are those 6 clinical groupings that will be chosen by the primary diagnosis. CMS designed the clinical groups to capture the most common types of care provided, and originally had specified 6 clinical groups, and then the number was doubled in the final rule, expanding the classification from 6 to 12 with the addition of 7 MMTA subgroups. MMTA groupings represent about 55% of all the projected 30-day periods when they looked at our information retrospectively. And so a majority of our primary diagnoses will fall probably into this category. Mary's going to go into a little bit more in depth on how some common primary diagnoses and the related clinical groupings here in a minute, and some of you are going to be surprised where the diagnoses actually fall into these clinical groupings. Okay, here we're displaying the differences between the two payment models. First is the billing component, and there's going to be, we're going to go from 1 final claim to 2 final claims for every 60-day episode. And then, of course, add in there the wraps for the time being, and your billing department's going to be busy with, you know, the wrap and the claim and a wrap and a claim, so 4 billing processes per episode. And then next, PDGM classifies each 30-day period as either a community admission or an institutional admission. And something that we are not identifying now in our current PPS system. Almost all second and subsequent 30-day periods will be classified as community. And the second and subsequent contiguous admissions can be classified as institutional only if there has been an acute care stay within the 14 days prior to the start of care. Interesting to note that any post-acute care stay within the 14 days prior to the start of care or any subsequent contiguous period will not classify as institutional, but will be community. With the episode timing, we now have the first 2 periods as early and the third as late, whereas with PDGM, the first 30-day periods will be classified as early, and each subsequent 30-day period will be classified as late. Moving into one of the bigger changes, with the service utilization or therapy count being eliminated. And according to CMS, we've all heard them say that therapy thresholds encourage volume over value, and PDGM will eliminate their use in determining payment, thereby removing any financial incentives to over-provide therapy services and really help shift the focus towards a more value-based system. And now I know the initial reaction may be to drastically cut therapy services for patients. So it's important to remember that the elimination of therapy thresholds does not mean that therapy services will no longer be paid for or valued. The new payment model ties therapy payments to the patient's clinical characteristics and their needs, particularly through that new functional component of PDGM and the scoring of the OASIS. Comorbidity adjustments. According to CMS, comorbidity is tied to poor health outcomes, more complex medical needs and management, and higher healthcare costs. So in the PDGM model, we'll designate a comorbidity adjustment of the low, high, or none for each 30-day period based on the patient's secondary diagnoses reported on the claim. The PDGM will allow home health agencies to designate 1 principal diagnosis and then up to 24 secondary diagnoses. And this is in contrast to what we're seeing today with our 5 secondary diagnoses currently allowed on the OASIS assessment plus our primary code. So a thorough assessment and ongoing reassessments and accurate documentation will be critical in ensuring you're getting the additional resources CMS is now allowing for the comorbid conditions. Clinical groupings. Currently we have the clinical aspect that makes up our HERG score, and it uses the diagnoses plus many of our OASIS questions like wounds and pain and shortness of breath. In the PDGM model, that the only thing that's going to count is the principal diagnosis will determine that clinical grouping and where that will be assigned. So it's important for home health agencies to clearly document what the principal reason for home health so that the most accurate clinical grouping will be used. And of course, we need to be cautious of any inappropriate elevation of secondary diagnoses into the principal diagnosis, as this will be a red flag for CMS reviews or audits. Then we have the functional level. This will be calculated similar to how we're doing it today with the low, medium, and high levels. Points, of course, will be assigned differently, and we will also have risk for hospitalization and M1800 grooming added to the calculation. OASIS item responses that indicate a higher functional impairment will be attached to, obviously, higher points, and I'll cover this all in detail at the end of today's presentation. Then finally, we have the RAPs currently, and they will be phased out over 2020 with full elimination of RAPs in 2021. So lots to go through, and I'm going to pass it over to Mary, who's going to start talking about some of the coding. Mary?
Okay, thank you, Amanda, and good afternoon, everyone. We're going to kind of hop into coding changes under PDGM, and one of the first things I really like to start off with saying is I know there's a lot of fear out there when we start talking about the focus being on coding, and a lot of agencies are saying, well, we're not coders. What do I, I don't have anything I can do about it. I'm not a coder. What I want you guys to focus on today is the definition of your diagnosis, understanding and identifying unspecified diagnosis or symptom codes or things that are not going to be valid under PDGM. If you're aware of the diagnosis, you don't have to know about how to code per se. So just focus more on the diagnosis and not so much on the coding. That's the first part of it. I definitely advise for all of our agencies out there. We're going to get started on the intake's impact on revenue. Intake is going to be your first line of defense. They're the first people to see in your referrals. The more information we can get out to intake and the more they are aware of what is considered a non-acceptable code under PDGM, the better off you're going to be. Because if there's certain key factors or things that we see all the time, like muscle weakness or abnormality of gait or, hip fracture without the size specified, if we can get that kind of information out in front of intake, it can be something at that point in the beginning before admission that we can send back and get more information and kind of keep those queries after admission to a minimum. Like we said here, we want to get clarification, as much clarification and information as we can get before admission. That's going to avoid those costly delays, because I think in the very beginning, it seems like, we have a hard time in a lot of cases getting that detailed information from the physician or from our providers out there. So we really need to try to stay on top of it. And of course, once we've admitted that patient, those queries, can lead into increased turnaround times and delays for RAP, and we don't want that. We want to try to make every preparation we can in advance to keep that on track. If a non-acceptable code is identified as the primary diagnosis with the focus of care, the assessment will not be able to be processed. Because if it's processed and you send it off, it's just going to return to the provider. Many EMRs, I know our own HH Code Pro, as well as your EMRs, are already setting steps in place for soft stops currently to just make you aware of non-acceptable codes and when that primary diagnosis will not be allowed from January 2020. So that's the biggest part of getting started into the coding point, is being aware of those diagnoses. Next slide, please. So, under PDGM, the primary code selected must be a valid primary code following PDGM acceptable codes. So, we want to remember, just because it says unspecified in the code name doesn't always mean that it's going to be a non-acceptable code, and we're going to touch more on that later. The primary diagnosis code is actually going to determine what clinical grouping the patient falls into, and we're referring to those clinical groupings that Amanda was just speaking of, those 12. They'll fall into that area, and that's going to determine the payment scale of what your patient's going to be into. It's going to set like the limits for low, medium, high for your functional scores. So it's going to set up the stage for the payment for that patient. Of course, just like it does now, the selected code must accurately describe to the highest level specifics the principal reason the patient is receiving home health services. So the reason for the primary diagnosis is still the same. We still want to make sure that we're being compliant with that, and gathering that information correctly. The biggest part here is that selected code still has to comply with current coding guidelines and conventions. So if you're seeing all that coding that comes in from us, you'll still see sometimes that we have to list certain things in certain orders. Those rules will still apply. Next slide, please. So here we put together some examples of some primary diagnosis and the groups they fall into. And you're actually going to be shocked by some of these. Some of these are pretty easy to see. Others, you really wouldn't think that's where it would be. In neuro rehab, you know, hemiplegia, hemopharesis, following a cerebral infarct. So, you know, that sounds pretty neuro. So, yeah, okay, we see that. Parkinson's disease, yes, neurodiagnosis. Alzheimer's is actually one of the ones that we normally get questioned about, because many people believe that Alzheimer's is a psych diagnosis, when in fact it falls into a neuro category along with Parkinson's. The one I was surprised by was the infection and inflammatory reaction due to internal prosthetic devices. I would think that would fall into more of a wound or an infection category, but it falls into neuro. So just know that the name of what you're coding or the diagnosis the patient has, it doesn't always fit where you think it would. So they've really got them kind of lined up in different areas. The musculoskeletal rehab, that's more cut and dry. You know, more of your aftercare following the joint replacements, your osteoarthritis, your spinal just a sciatica right side, your degenerative disc disease patients. You know, those are going to fall into your musculoskeletal rehab. So it is a bit more, you know, phase into what you would think of musculoskeletal. Next slide, please. Now, wounds is where it starts to get a little crazy. The things like diabetic ulcers, I would see here is that E11621 code. That's a diabetic ulcer with a diabetic patient with a foot ulcer. You know, that's easily going to put you into the wound category. But notice the question mark next to venous ulcers. Because of coding conventions and things like that in coding, even though your primary focus of care may be a stasis ulcer, because of coding, it requires a code called venous insufficiency to be coded primary, and that code falls into circulatory, MMTA circulatory. Even though your primary focus of care is a wound, you can see just by coding rules, it can actually slide you into a different category, and that's really where it's going to put you. Now, we're doing some questioning on that, and there's a lot of questions going out into industry currently to get CMS to confirm, okay, we're dealing with wounds, why aren't we in the wound category? So we hope to get some additional information on that coming soon, and as soon as we get that, we'll be able to update you guys and let you know what the change is. Other items are pretty much what you expect to see: burns, traumatic wounds, atherosclerotic ulceration, and wounds due to varicose veins, which are also a type of stasis ulcer. So things like that you kind of expect to see in wounds. And your complex nursing interventions, those are pretty simple. If your primary focus of care is going to be attention to a device, so we're talking about care to trach, care to G-tubes, urinary catheters. If those are your primary focus of care, your patient's going to fall into a complex nursing intervention clinical grouping. So just to kind of give you some ideas of how those diagnoses fall into those groups. Behavioral health, that's pretty cut and dry. If your codes start with the F code, F like Frank, then you're talking about, you know, schizoaffective disorders, major depressive disorders. That's going to put you into behavioral health. And then you have your MMTA, which we've only got one here, the MMTA other, but there's also MMTA respiratory, MMTA circulatory, other items like that. But I did want you to notice on the other, they have hyperlipidemia unspecified, plain old regular hypertension, and diabetes without a complication. Because there are some conversations that I've been seeing going on online that actually say that people are thinking, oh, well, we can't use diabetes without complications or hypertension. That doesn't fall into a group. Well, it does actually fall into a group. MMTA other is still a clinical grouping. So unless it comes up and says it's non-acceptable, and it doesn't, because these codes are still acceptable, they're still usable. And even that hyperlipidemia that says unspecified, a lot of people are thinking, you know, that hyperlipidemia says unspecified, that's non-acceptable. No, it actually falls into MMTA other. So don't let the name of the code with the inclusion of the term unspecified fool you into thinking that that's not acceptable because of that term. It isn't always the case. So you can actually refer to the website at CMS to get a full list of acceptable codes under PDGM to kind of help you with that. You shouldn't have to really look through it. Your EMRs are going to do most of the work on that and make you aware of it. So let's start talking about those non-acceptable codes under PDGM. And again, the non-acceptable code under PDGM are codes that are deemed by CMS that we are not allowed to place in the primary slot. They're still okay for secondary. So if we're still using them later on, they're still valid codes, not going to become invalid. But you just cannot put them in the primary diagnosis. It can't be your focus of care. And CMS has given us a threefold reason of why these codes are deemed non-acceptable. They're either the patient itself that has it, it's not appropriate for home health because it's something we really aren't treating, it's too vague or non-specific, or it could be, like I say, you're too acute. So it may be something like a stroke patient who has an acute stroke. You know, we still can't treat that as acute fractures. We still can't do anything with those acute phases of those diseases. Or the codes are just simply not specific enough. We're talking about the non-specific codes that are non-acceptable, as well as symptom codes that don't have a definitive diagnosis. So they've actually identified those and put them into those three categories. And that reminder that the term unspecified alone doesn't make the code non-acceptable. Next slide, please. So what we've done here is we've actually pulled a report of all of our quarter clients and pulled together and have the top 20 non-acceptable codes that are being used currently by our quarter clients. And of course, as you see here, the #1 non-acceptable code we see is muscle weakness. Big shocker. I know we see that all the time. You know, so muscle weakness is deemed as a non-acceptable code. As of January 2020, it will no longer be allowed to be placed as primary. What we'll need to do to get additional information for that is find out what is the underlying cause. It's not going to be something that we're going to be able to guesstimate or assume. It has to be documented. If you don't have that documentation, you can get a verbal confirmation and document that into your documentation to kind of let the coder know, or make sure if an auditor comes in, they can see it, or when they run your chart, they can see that you have a specific reason stated for the muscle weakness, or in some cases, the muscle weakness can be further specified, such as muscle atrophy or muscle spasm. Even though those still sound pretty non-specific, they're allowed codes. They're not acceptable. Things like osteoarthritis, low back pain, abnormality of gait. You know, osteoarthritis can actually go from being a non-acceptable code to an acceptable just by getting the laterality in sight. So instead of osteoarthritis, not otherwise stated, you end up with osteoarthritis of the hip. Now we can do something with it. Or osteoarthritis of the right hip. Now we can do something with it. So it gets more specific as it goes more into it. Back pain, you know, general aches and pains, malaise and fatigue, we're going to need to get in there and get that information up front and find out, get it documented, what is the cause of these symptoms. Because the more we can get on top of these type of diagnosis and symptoms and understanding, get them in front of our intake, get them in front of our admission staff, let them know, okay, this is going to be a problem. I need to go ahead and start to work on this so it doesn't cause a hiccup later in the process. So that's the biggest thing of showing you guys this particular slide to make you aware of the type of diagnosis that are coming out most commonly as a primary diagnosis. Next slide, please. So symptom coding. You know, over the years, as coders like myself, you know, we don't enjoy using coding symptoms. And many of you out there just do not want to code symptoms at all. And coding guidance has always limited the use of symptoms by the guidance that tells us that we are allowed to use symptoms in the absence of a more definitive diagnosis. But if you know the cause of the symptom, you're going to code the cause and not the symptom. So we still have that rule, and it's still going to apply to secondary diagnoses. But under PDGM, that rule will not fall for primary diagnosis. So even though there is that coding guideline that says we can code a symptom if it's not a definitive diagnosis, under PDGM, it's not allowed. So we will have to dig deeper. We will have to get that documentation to support your primary diagnosis. Next slide, please. Here's another example of some of the non-acceptable codes, abnormality of gait. We see this a lot. It's also known as gait disturbance, difficulty walking, frequent falls. All of that falls into the abnormality of gait kind of category. Of course, we should not be coding that when the reason is known, such as orthopedic conditions like osteoarthritis or fractures, or even neurological conditions like Parkinson's disease that include a gait disturbance. So, you know, in most cases, if we see a patient who has one of these types of disorders, generally we will find something in the chart that relates to two, such as osteoarthritis in the hip. The patient has abnormality of gait. You know, it's basically tied into the lower extremity. So in those cases, it does allow us to pick up a little bit on that, but otherwise we would need more definitive documentation to make sure we're getting that accurate as possible. And of course, anytime we see abnormality of gait come in as a primary diagnosis, we want to make sure that we're getting that information up front, because it is not acceptable and we can't code it. Not as primary. Generalized weakness is another one of our main culprits. Generalized weakness and or muscle weakness. It's the most common complaint. It's my least favorite code, because I tell you, either I have this code now myself, or I'll have it later today, and I say at least 50% of you fall into the same boat with me. So it's a very non-specific code. It can be caused by any amount of reasons. Lack of sleep can cause this code, anything. So we see this actually quite a bit as a primary diagnosis, which is kind of unsettling, and one of the reasons why CMS is deemed this as not acceptable. If we see this as a primary focus of care coming in those referrals, we want to go to the physician and say, hey, you know, under PDGM, we can no longer accept this as a primary diagnosis. Can you give me additional information telling me what's the cause of this generalized weakness? What's the cause of this muscle weakness? You know, do they have something else tying into this? Is it all these other diagnoses, one more than the other? We really need to get more information up front. So as you're seeing a pattern here, it's more the documentation has to change under PDGM than it does the processes. So you kind of see that more as we go along. Next slide, please. So here's some examples of some unspecified codes, and these are our general culprits that we see a lot of times in documentation. It'll just say hip fracture, or it'll just say osteoarthritis. And again, what information do we need to make these codes acceptable? We need terms like things like laterality and specified site. And it is important to remember that coding clinic has actually identified that the clinician is allowed in obvious cases, like if we're talking about the patient has a hip fracture and the clinician sees that the hip fracture is on the right side, they have a cast on their right leg. It's pretty clear it's their right hip fracture. So we are allowed to accept that information as the clinician adds in that laterality in cases where it's obvious. We wouldn't be able to do that in a case such as lung cancer or something internal where it's not obvious, but things like you can see it, it's on the right leg, okay? You know, so those types of things, coding clinic has agreed that we are allowed to take that information from the clinician to further specify the laterality of those conditions. So if we have that information, make sure we're doing everything to get that documented. Next slide, please. Some other symptom codes, right leg pain, shortness of breath, back pain, we see these quite a bit. They come in as the reason why we're seeing the patient, you know, and this is something that CMS is really harping in on. You know, what is the cause of that back pain? What's the cause of the shortness of breath? Why is their leg hurting? You know, we need to query on that. If it's not documented in the chart, query to identify the cause of the pain and shortness of breath. And again, reminder, muscle weakness, not acceptable. We keep putting that up there because we see that used so much. And right now, it's almost like a catch-all when we don't know what else we're doing. You know, what else is happening? All I can get is muscle weakness. There's no cause stated. There's nothing to link it to. There's nothing. So you end up with muscle weakness primary. And trust me, we hate it as much as you hate seeing it. So hopefully, with this new rule under PDGM where it's not allowed as primary, we'll really be able to push and get those providers to give us additional information. That's the whole hope of it anyway. Next slide, please. So here's some common query suggestions. It is important to remember that we're always using appropriate query practices per your agency's policy. We do advise that a lot of these queries you probably do want them happening at intake just because it's before we've actually gotten into the admittance phase, the clock's not really ticking. It is important to remember if you're using multiple choice that you are also allowing an other option. So if you list multiple diagnoses in a row, always offer that other or another diagnosis, please list here, type of query. So you're not sticking them into one area. You're allowing them to give you open-ended responses as well. So in this case, we have muscle weakness, M6281. PDGM says that's too vague. We're not going to accept that as a primary code, so we need to query. We're going to ask what the condition is that's causing the muscle weakness, or can the generalized muscle weakness be further specified, like we talked about before, as muscle atrophy or muscle spasm. Something to get a little bit more specific than just generalized muscle weakness. Next slide, please. And here's an example of what I was talking about with the multiple choice. We have low back pain. Again, PDGM says that's too vague. I'm not going to accept that as a primary diagnosis. And here's our query. Does the patient have a condition like a strain, spinal stenosis, degenerative disc disease, fractures, or another reason for the back pain? So that way we're leaving. Or if it's not on this list, can you tell me what it is? So we're really giving them information of what we feel like it might be, or an idea of what it could be, but we're also giving them an other. So we want to make sure if we are querying that we're being as appropriate as possible. Next slide, please. So let's go into the wonderful world of comorbidity adjustment. I know everyone's interested about this. So, next slide, please. Our comorbidity adjustment under PDGM. When we start talking about comorbidity adjustment, it only includes your secondary diagnosis. This has absolutely nothing to do with your primary diagnosis. Your primary diagnosis is only used to identify the clinical grouping. So that's where it's going to put it at. So we start talking about comorbidity adjustment. Remember, it has nothing to do with primary. It's only from the second code down to number 25. Because again, we're going to have 25 of those. As it said here, includes all secondary diagnoses up to the additional 24 versus the 5 that we have now. So now we have 5. Under PDGM, we'll have 24 diagnoses that are going to be on the claim. The comorbidity adjustment can actually fall under none, low, or high. That's based on this. Oh, I'm sorry. None, low, or high based on the diagnoses that are present. So again, we're talking about what's present for each patient is going to be important. It's not a whole lot that we can do about, getting the right diagnosis, but we can make sure that the patient's medical history is clear, detailed, and gathered. We get all that information to pull up to make sure that we are properly addressing, everything on their plan of care. We're getting all that information coded, and it's properly identified. You can actually receive a payment for a low or high comorbidity adjustment, but not both. So whichever one is higher is going to be the one that you get. And it doesn't matter about how many codes you're coding. Even though you're allowed to code up to 25 codes, coding 25 codes is not going to make the payment go up. And you'll see more about this in a little bit. It's more about what diagnoses are captured. You could easily have a high diagnosis with only 3 codes. You could have a low diagnosis with only 2. So, it just depends on which one it is. But just don't get too overwhelmed thinking that you need to have 25 codes on every chart because you're losing money. That's not the case. It's more about coding for the quality of the patient and what quality diagnoses are present on the claim. It is important to remember that comorbid conditions that are within the same ICD-10 group as the primary diagnosis are excluded for consideration as a qualifying comorbid adjustment diagnosis. An example of that is a patient who has a sequela or late effect of a stroke. So they have both hemiplegia and they also have dysphagia. So just one is primary and one is secondary. Well, now the second code that falls into the same category doesn't count towards your comorbidity. So that's something to remember when you're looking at this. But a comorbidity adjustment can actually increase your payment up to 20%. So it is important to be aware of it and understand that gathering that information and making sure that we're getting all of that information to make sure we're getting it on that plan of care, it's making it to the claim is even more important than ever before. Next slide, please. So like we talked about, well, we haven't talked about this, but we have 12 comorbidity subgroups associated with lower resource use. So to qualify for a high comorbidity adjustment, the claim actually only needs 2 or more secondary diagnoses. But those 2 diagnoses, at least, have to fall within 34 comorbidity subgroup interactions. We have a lot of slides on this next, so you'll get a chance to kind of look at it. But only one comorbidity adjustment can apply within a 30-day episode. So even if you see multiple cases where you can get high, you're only going to get it one time. And I was very interested when I saw these statistics that 62.6% of all of our assessments will have no comorbidity adjustment. And again, it really falls into the things like we talked about with the primary diagnosis being in the same category, or not having the diagnosis that actually fall into any of the categories. Only 31.6% will fall into a low comorbidity adjustment. And ready for this? 5.8%. Only 5.8% of our assessments are considered for high comorbidity adjustment, just because it's not as easy as everyone thinks. A lot of people were thinking, well, I'm coding 25 codes. To be sure, I'm going to hit something. Well, there's going to be times that you are, but as you see by this percentage, it may not be as often as you think. Next slide, please. Okay, so let's get an idea about how do we get a comorbidity adjustment, a low one. So a low comorbidity adjustment requires at least one diagnosis for one of these comorbidity groups listed below. Just one of them in a secondary diagnosis slot will give you a low comorbidity adjustment. Now, when you look at this, you're thinking, oh, well, I see lots of patients that have follow the CVA, lots of patients that have varicose veins, lots of patients that have arrhythmias and heart failures. I see lots of those. Well, the problem is when I look at this, when I see it, and many of you look at charts every day, you'll notice that a lot of these diagnoses are commonly our primary focuses of care. And again, if they're our primary focus of care, again, they don't count for our comorbidity adjustment. So if we have one of these as our focus of care and then another one as a secondary diagnosis, now we get a primary, I'll get a low comorbidity adjustment for that patient. So there is a little trick to it, and that's kind of how it works. So let's have a look at an example of a low comorbidity adjustment on the next slide. So here we have a primary diagnosis of hypertensive heart disease with heart failure. This puts it into MMTA, cardiac and circulatory clinical grouping. We have a secondary diagnosis of that heart failure. That is a low comorbidity subgroup of heart 11. Because of that, that gives us I-50, that's low comorbidity, and now we have a low comorbidity adjustment with just 2 codes. Now, if there were additional diagnosis, again, it can make a difference, but just low comorbidity just off 2 codes. So again, it's not about the quantity of the codes that you have, but the quality of them is going to make the difference on this. So let's go to the next slide and have a look at high comorbidity adjustment. And if you've never heard this before, the first time you hear it, it's going to mess with your mind because it's kind of hard to identify right off the get-go. So trust me, if you hear it today, look over it again and again, ask questions about it, get a feel for it, because once you get your head around it, it's not as bad as it looks, but it sounds a bit crazy. But you get a high comorbidity adjustment when you have 2 or more diagnoses that are linked with a higher resource use when both codes are reported together. As we see here, under the comorbidity subgroup interaction 1, we have behavioral 2. So if we have a patient that has in the secondary diagnosis some depression or bipolar disorder, and they have a alteration that falls into skin 3. So if you have both of those at the same time, you get a high comorbidity adjustment. Same thing under the number 2. You have a patient who has a secondary diagnosis of a sequelae of cerebral vascular disease, also known as the late effect. And you have a diagnosis from circulatory 4, which hypertensive chronic kidney disease falls into that. If both of those are in your secondary slot, now you're in a high comorbidity adjustment. So you can see how sometimes some of these diagnoses would actually cause you to fall into, it would be in your primary diagnosis, so you would lose out on the opportunity for it to be a comorbidity. So there are times it's going to be tricky, and that other one that you see there, one of them will be your primary, and you lose out. So that's where that 5.8% falls into. So in the next couple slides, we actually have a few other pages and upon pages, basically, of interaction groups of diagnosis when paired with another diagnosis, and they're both secondary, that create together the high comorbidity adjustment. So I definitely advise taking some time, looking through your slides, and identifying yourself. If you're in one of those positions where you're looking for that information, yeah, this is how it'll help you understand when you have a low versus when you have a high. And on the next slide, we actually have an example of a high comorbidity adjustment. And it's very similar to the previous one. We just added one more diagnosis. So now we only have 3 diagnoses. Our hypertensive heart disease with heart failure is still primary. We still have that secondary diagnosis of the heart failure, which is a Part 11 subgroup. So that's a low comorbidity right there. But just by adding the Parkinson's disease, and that's in a comorbidity group of Neuro 5, so we have a Neuro 5 and a Part 11. Now, with just 3 codes, we have a high comorbidity adjustment. And when you look at it that way, you think, I see that happen a lot. I should get a high comorbidity adjustment a lot. And you very well could be. It has a lot to do with the combination of diagnosis that each patient has. So we may see more of them, we may not. It depends on what they've had, what they have, and what your primary focus of care is. Next slide, please. So I know everyone's been having questions about, COPs, and the fact that they say, that the patient, if you're supposed to be gathering information, you should be coding all pertinent diagnosis, and by all pertinent diagnosis means all known diagnoses. So we do hear that a lot. Unfortunately, there is a coding guideline that doesn't exactly line up with that, and we're really hoping that they're doing some talks about it and lining those 2 together. They haven't done it yet, but it does make life between agencies and coding rather bumpy. The reason why is because under coding guidance, we have a certain level of requirements stated by this coding guidance under Section 3 that only require us to add secondary diagnoses when they meet one of these criteria. So here we have the reporting of the definition for other diagnoses for reporting purposes. Is determined as additional conditions that affect the patient care through requiring clinical evaluation or therapeutic treatment, diagnostic procedures, extended lengths of hospital stay, or increased nursing care or monitoring. What we're trying to do here at Corridor is to make the coders painfully aware of when they should be adding those comorbid conditions. And most of the time what we see is they do a pretty good job with gathering comorbid conditions. We want to make sure that we're gathering everything as much as possible and look for every opportunity and set tighter criteria about reporting secondary diagnoses. So things as simple as therapeutic treatment. Does the patient have a diagnosis for this one? So is it a confirmed diagnosis? Yes. Are they taking medication for it? If the answer is yes, right there, it qualifies it to be coded as a secondary diagnosis. So as you can see, there are times that a patient may have a diagnosis that isn't taking any medicine for it. It may be something they were diagnosed with a couple of years ago. It hasn't reared its ugly head or exacerbated in a past couple of years. And sometimes we do get questions about that of why that particular diagnosis wasn't coded. And if it doesn't fit this criteria, and in the situation I just described, it wouldn't meet the criteria for secondary diagnosis. So if you're seeing there are times there are comorbidities that are being left off, that's why it fails to meet this criteria. So what can you do as an agency to help meet this criteria? Is put it in there. If it's something you're wanting to be coded, if it's something that you are addressing, something that you're wanting to see, it needs to be documented. It needs to have something documented. Is the physician still treating them for it? Are they going to the doctor for it? Is it just something that's not requiring medication at this point? Is there some sort of therapeutic treatment that's going on for it? Because that will help the coder, us, at Corridor, identify, yes, that meets the criteria for secondary diagnosis, and it needs to be added to the claim. So that's some of the things that we can do together. And when we work together at that and get those 2 together, we can make sure that what you're expecting to see under your COPs will align with what we're coding almost every time. Next slide, please. So the Medicare Claims Processing Manual has given us some new language. I know many of you who's been around for ages like myself knows that they always tell you everything has to match. The OASIS, UB5, all of that, everything has to match, claim, all of it. But now they've given us this new updated language that for the claim from dates on or after January 1st, the ICD-10 code and the principal diagnosis used for payment grouping will be claim coding rather than the OASIS item. As a result, the claim and the OASIS diagnosis codes will no longer be expected to match in all cases. So there still are times you're going to expect it to match, but not every time. And what we found is that this more applies to the second 30-day period that you've all heard about under PDGM, where the primary diagnosis may need to change, whereas the beginning OASIS may not. So that's when you see this language, that's what that refers to. It doesn't mean that it doesn't always have to match on every chart. It doesn't have to match on every chart all the time, but there are times that it will not match and it will still be acceptable. Next slide, please. So just a little follow-up, making assumptions for coding, just to make everyone aware of it, that the assumptions that you see coming in, if you're looking at charts that are coded, or if you're a clinician on the field that's signing off on codes that are coming back, those crazy times when you say, oh, our congestive heart failure is the reason why I'm admitting this patient, but it comes back and hypertension is listed as primary. Why are they doing that? That's because of these assumptions that the ICD-10 code set they make. So it's important just to reiterate that the ICD-10 classification, the code set itself, assumes the relationship. We as coders have to actually follow it. So it will still cause your primary diagnosis to be different sometimes than what you believe was supposed to come back. So those assumptions, the only way we're allowed to not make these assumptions is if the physician states that conditions are unrelated. If it's just documented, the ICD-10 manual itself will require those codes to be listed together or listed as related. So it's not something that the coder is doing, it's something that the code set is doing. So we don't like it any better than you guys do. But if you ever see it and you have questions about it, or you're wondering why something's coded the way it is, reach out to us at Corridor. We'll definitely be able to give you an answer on that and help you understand, why it has to be that way. We know it looks crazy sometimes, but it's just what the guideline actually requires us to do. It is important when we start talking about the face-to-face and the plan of care, and I hear this a lot, and I know there's lots of MACs out there and payers that are coming back to the agency and giving you guys a hard time. We hear a lot of that in the industry, but there isn't actually a regulation that states that the primary diagnosis must be identical to the face-to-face. But it does state that the face-to-face supporting documentation should have information that is related to the primary diagnosis. So even though it may not be identical, there needs to be documentation of some relationship. And I understand there's times that can be actually really hard, especially when you have a face-to-face that happened a little while before you're actually admitting the patient, and those conditions or the condition that's listed as primary may have already been resolved by that point. So it may not even be applicable any longer. So situations like that. So it is important to remember that there are times that the primary diagnosis and the face-to-face primary code identified will not be identical, but as long as they are related, we're still following the regulations for face-to-face. On the next slide, we should have an example of this type of situation. So here we have a face-to-face that states the reason for home care is muscle weakness of the left lower extremity. Pretty specific. But the patient also has a current left hip fraction. And of course, in the documentation, it's clearly causing the weakness. Following coding guidance, the fracture would be coded and not the muscle weakness. We would do this even though muscle weakness is what's on the face-to-face. The documentation actually shows the relationship between the two conditions, and since the two conditions are related, this should satisfy the face-to-face requirement. And if there are any times out there that you guys are getting any kind of denials or anything, any pushback or questions from your payers or from your MAC, reach out to us at Corridor. We have a team here that's set up to be able to help you with that information, to get you individual information from the coding guidelines or what you need to send it back to your MACs or to your payers to specify and explain why it's coded the way it is. So if you're seeing those, reach out to us at Corridor and we'll get you all the help we can get for you. Next slide, please. So here we have some examples of going into the face-to-face. And this is some of the things that maybe you see as clinicians or intake staff or admission staff as you're going through even QA. So you'll get some ideas of here of acceptable versus non-acceptable documentation. So here's the first one, and like I said, these are little snippets from actual medical records that we see, just to give you some examples of vague or good documentation in some cases. So our first item here is we have a 68-year-old female that presents for lumbar spine and left knee pain. Well, we know what pain is, at least that's one specific, but unfortunately, both of those are not acceptable under PDGM. So we would need to either find out, do we know the cause of the spine and knee pain? And if we can't, if it's not documented and we can't see what it is in there, then we're going to need to query that. So that's going to be an example of something we would have to query if that is our primary focus of care. If that's secondary, it's still allowed, but not as primary. The second example here is dyspnea. And for any of you out there that don't specific coders, you would think if this gives a nice long sentence. Unfortunately, it says possible asthmatic component versus cardiovascular etiology. So when it says versus, that means absolutely nothing. We can't use it. In an outpatient setting like home care, we're not allowed to take that documentation as anything other than shortness of breath. So it doesn't give us an actual etiology. If the shortness of breath was our primary focus of care, we would have to either find it in the documentation or query it to the physician and get them to identify for us what is the cause of shortness of breath. Now, the third example here is a little bit tricky if you haven't seen it before. Here we see symptoms like low back pain and neck pain, but we also see diagnosis of lumbar and cervical radiculopathy. Because the cause of the pain is listed here in the list, this wouldn't require any additional query. We'd be able to take this information and run with it. We can code based off of this. We've got enough here to do what we need to do, and no query is required for that. Next slide, please. So here's a lovely example of a very vague face-to-face, and I'm sure many of you have probably seen this one, probably one just like it come in. We have a nice little list of documented, a list of diagnoses, goodness gracious, listed at the top left-hand corner of hypertension, generalized muscle weakness, and other lack of coordination. When you go down a little bit further and look underneath the second red circle, we see it's therapy only. So unless, if the primary hypertension is the primary diagnosis, unless we have documentation that the hypertension is causing the generalized muscle weakness or lack of coordination, then we have a problem. We're going to need to find that information in there. What is therapy treating? If they're treating the muscle weakness and lack of coordination, which is probably more than likely what they're doing, and we need to have a cause documented for that, because if that is our primary focus of care, it is not unacceptable. So we're going to need to get more information. So either we find that in the assessment, or we have to query to the physician to get more information about the cause of the muscle weakness and lack of coordination. Or if hypertension, for some crazy reason, could play a part in that, because when they list about that on therapy only, it tends to make it look that way, even though we all know that doesn't make much sense. Next slide, please. So here we have an example of good documentation. So this is really what you want to look for when you start looking for face-to-face documentation. It should be in progress note format. We have a discharge diagnosis. We have a good medical history on this patient. It tells us a lot of things that are going on with it. We have a history of diabetes, on insulin. It even goes further to specify that it is a left-sided pulmonary embolism. You know, we're continuing weight-based Lovenox. So it gives you more information about what the patient has and what kind of care they're going to be needing ongoing. So good documentation there. That's the type of stuff you really want to be looking for and expecting from our providers. Next slide, please. Okay, so here is actually, it doesn't look like a scary slide, but this is a scary slide. Mainly because under coding guidelines, and I know all of you aren't coders there, but there are rules that require us as coders to list primary, list symptoms as primary. Here we have a patient who has a TIA, which if any of you that are non-clinical out there, that is a mini stroke for any of you non-clinical people. But so we're not allowed to code a mini stroke or TIA in home care because it is too acute. They're saying there's nothing we can do in home health to treat that patient. That if you go there and the patient's having a mini stroke, we have to call the emergency department and get them to the hospital. Nothing we can do in home health that can treat that. So they tell us we can't code that. The only other things we have on this patient is multiple falls, ataxia, and weakness. All of those are non-acceptable. So under this, under PDGM, there's literally nothing on this chart following the current guidance for PDGM that could be primary. So our question, going back to CMS, along with a lot of people in the industry, is what about patients like this, where the guidance itself requires a symptom code to be listed primary, or that's all you really have? And there are some conversations going on in the industry with CMS that there are times that a muscle weakness code or a symptom code needs to be primary when there's nothing else, and that's what the guidance tells us. Either they need to change the guideline and give us more information, or change it under PDGM. So what's going to happen with that? We're unsure. At this point, if we get this patient currently or under after January 1st, we would have to query the physician to get something more specific to put as primary. Because as written, if there's nothing else, we wouldn't be able to even bill for a patient like this. So that's some of the concerns we have. So as soon as we get some more information concerning that, we'll definitely keep you guys in the loop and let you know. So here we have another example of good documentation. We have the reason the patient was referred to home health, respiratory failure with hypoxia, pulmonary hypertension, and a new trace. So we've got 3 things going on there, and all of those are acceptable. So we have a nice progress note type documentation once again. It gives us some information that the patient's on oxygen. You know, it has the intent of the patient caregiver performing daily trait care. So it's a lot of detail, and that's really what you're wanting for a good face-to-face, a good, you know, something good documentation that you can pull off of, set up your plan of care, and code from. That's really what you're looking for. So this is a good one for us. So here's another vague opportunity of documentation for face-to-face. If you start seeing referrals coming in, the patient was referred to home health for decreased mobility, not acceptable, due to bilateral leg pain, also not acceptable, and a fall due to weakness, majorly unacceptable. So we know nothing on this referral that we've gotten for this patient is acceptable. So in this case, you know, they're saying all of this happened due to weakness. Well, what's the cause of the weakness? Or do they have a wound on their leg? Is it an actual injury where they, you know, have a wound they're going to be dealing with? We look down even further, looking for help, thinking under the patient's medical history, maybe we'll find something. Well, here we have memory loss, hyperlipidemia, and anxiety. Woo, big help, right? So in cases like this is an example of the type of documentation that we see now, and the kind of documentation that you agencies out there are probably seeing as well. And right now, we're kind of forced in some cases when we query and we ask for more information and we don't get it. It's like, well, we have to cover what we have, and that's what's left to all of those non-acceptable codes being listed as primary. But in cases like this, we're going to have to stop. We're going to have to query. We're going to need to know what's the cause of the leg pain. You know, it's from a fall. Did they pull something? Is it a strain? Did they cut their leg? What's going on with it? Is it a muscle tear, contusion causing the pain? And what is the underlying cause of that weakness that made them fall to begin with? You know, so the physicians, providers out there are really going to have to step up their game, and we're going to have to really push for that to get that more specific documentation to keep these non-acceptable codes off of our primary diagnosis list. Next slide, please. All right, so we're going to turn it back over to Amanda to talk about PDGM and OASIS. Back to you, Amanda.
Thanks, Mary. Lots of good information about coding, so I hope you guys are taking away some good things there. So we're going to move into how the OASIS is going to impact PDGM. You can see here that there will definitely be some reduced amount of OASIS questions that will impact payment, because as we know right now, things like therapies in the home and wounds and pain and dyspnea all kind of play a role into our calculation. However, it's really important, even though that they're not going to be impacting our payment, things like pain and dyspnea is still going to be really important because of course, our 5-star and those of you who are participating in the value-based purchasing. So we can't take our eyes and attention off of still continuing to review and educate our clinicians in those areas. But as far as the functional impairment and the low, medium, and high, points are going to be attached to certain OASIS responses, which you're seeing here in this chart. And CMS will use a certain model to assign functional impairment thresholds, or low, medium, and high, to each of the PDGM clinical groupings, which I'll show you here in just a second. But what I want to point out to you is that we really want to make sure we're ensuring that the clinicians understand the fine details between the response options for our OASIS questions, because this can mean a difference from 3 points to 12 points for things like bathing, if you want to turn your attention there. So while Corridor is reviewing the record, it's important for there to be documentation that identifies that the patient requires intermittent assistance, which would correspond with a 2, or continuous assistance, or response 3. And oftentimes, unfortunately, what happens is we get into the chart and all it says is families assisting with ADL cares, or patient needs ADL assist. And it's hard for us to determine whether the patient needs intermittent assistance or continuous assistance. And it's going to be pretty important in this new payment model in the distribution of the points here, as you can see. Also, I want to turn your attention to dressing and ambulation, because right now we do get points for response 1 for dressing and ambulation, whereas in this new payment model we're not going to anymore. And this will probably more impact our dressing, where I do see a lot of response 1s. And so we want to go back to our clinicians and really make sure they understand what's all included with the dressing task, like taking off prosthetics, orthotics, and other supportive devices. So here you can see those thresholds, the low, medium, and high. Obviously, high is going to be tied to higher points, functional scores, and therefore you're going to get higher resources to take care of that patient versus a low. And then they're going to be attached to these clinical groupings, the 12 clinical groupings. And again, getting the right principal diagnosis for the clinical grouping is going to be important, because it's all going to play a role in how many or which threshold you're going to end up in for the functional level. For example, you get 38 points for MMTA cardiac, and this 38 points puts you in a medium functional level, whereas 38 points for complex nursing, if you draw your attention there, will only put you in a low functional level. So again, the accuracy of the whole comprehensive assessment and the way things are paired becomes really important. And in making sure that the coders and the clinicians, actually the clinicians, are identifying the focus of care is clear, and then we're therefore getting the patient into the right clinical grouping. This leads us to how can Corridor make a difference in your OASIS responses. Understanding our process on what information we use to suggest changes or not suggest changes helps ensuring we are both providing what we need to make this partnership successful. Sometimes we even find out that we need to align differently on what information we are using to support changes, or encourage the clinician to maybe add some supporting documentation so Corridor has enough information to reconcile the clinician's OASIS response. Obviously, Corridor is using the clinician's documentation, the narratives, to make changes to the OASIS. This is generally where we find conflicting information to say that, you know, what the patient or what the clinician had scored this answer as is not quite matching up with what he or she documented in the narrative or in the other sections of the comprehensive assessment. Coders will also look at visits within the assessment time frame, especially the PT-OT notes, as these generally will provide information that conflicts with the clinician's OASIS score, and it gives us enough information to suggest a change and build our rationale statements on why we think it should be different. If a clinician has scored an item a certain way and there's no supporting documentation for that response, or there is nothing to say it should be different, the clinician's response will remain the same. Like in the example I had used earlier with M1830, the clinician had scored M1830 as a 2, needing intermittent assistance for things like getting in and out of the tub, and there was nothing to suggest that the patient required continuous supervision due to safety concerns or any other conflicting information that may be found in the OT note. The clinician's response is just going to remain the same. So any additional information your clinicians can give us, especially differences between intermittent assistance, continuous assistance, and things like bathing and ambulation, certainly do help in identifying what the correct OASIS response should be. And again, this is kind of why we encourage clinicians to provide a functional summary in some way in a narrative form, or in some additional documentations in a template, however that might come across. This does help us in making sure that the OASIS response is accurate, using that additional information to reconcile the clinician's response. For M1033, to provide payment points, there needs to be 4 or more responses selected here, excluding options 8, 9, and 10. And you can see M1033 is definitely a little bit more comprehensive than some of the other OASIS items, as it has various different look-back periods, and it encompasses a wide range of signs and symptoms. Corridor will use what we review in the HMP and in other patient attachments to reconcile this item. We can obviously use some of the 1700 items to look at that response 5. We can look at the fall risk. And looking at the patient attachments, we can usually identify if the patient had been in the hospital in the recent pertinent past. And so we'll gather that information to reconcile this item. Any type of additional documentation, like having the clinicians answer some yes/no questions, again, gives us enough information to rectify the M1033 response and can be very helpful as we partner together to ensure you're getting the additional points if necessary. And there are quite a few points, 11 points if you can get 4 or more selected there, without the exception of 8, 9, and 10.